Good afternoon, everyone.
Good afternoon, everyone. Good evening. We will be getting started in a few minutes, just giving a 5-minute grace period to any potential latecomers. But we are going to be getting started very shortly. Just bear with us 1 minute. Thank you. Okay. Good evening, everyone. Once again, we are going to get started now, and we will open with a word of prayer. Heavenly Father, bless us all gathered here today with hopeful spirits as we come together to address the challenges and triumphs surrounding cancer. We ask for your presence in this meeting, guiding our discussions. May we honor those who have been affected by this disease, patients, survivors, and their families. Grant us the wisdom to understand their struggles and the compassion to support them in their journey. As we share our thoughts and ideas, may we be filled with courage and determination to make a positive impact, that our efforts be a source of light in the lives of those fighting this battle. Thank you for the opportunity to come together in this important work, and may our meeting be fruitful and our hearts united in purpose. Amen. Welcome, everyone. Welcome to our March meeting under the topic of colorectal cancer awareness. Can you believe it's March already? How the year is flying by. All right, so we will kick off the evening with any announcements. Anybody celebrating birthdays, anniversaries, milestones they want to share? Feel free to either open your mic and let us know, or you can put it in the chat and we'll read it for you. Any celebrations? Nobody? Nobody have a birthday? Wow.
I celebrated one at the end of the month, the 28th of February.
Well, that's since our last meeting. So happy birthday to you, Sue Culmer, all the way in Eleuthera.
Thank you. And
Belated
this
birthday
Saturday,
parties
we'll
to
be
you. Hope you have a
celebrating
wonderful
our ball.
celebration.
And our
Sorry?
ball will be on, we're hosting our annual hook ball on Saturday.
That's over in Eleuthera, everyone. So if you happen to be in the neighborhood, feel free to drop in and let Sue know. Help them celebrate and
Tickets are still
fundraise.
available?
Yes, ma'am.
Okay, there you go.
Just a few because we're capping at 100.
Wonderful.
And I'm sure it'll be a wonderful evening. Okay, anyone else? Okay, so Erin, I would let you now do our announcements and upcoming events.
All right, good evening, everyone, and welcome again to our monthly general meeting. This month is somewhat quiet after a busy first part of the year, with January being golf and February being our Stride for Life, which was very successful. Thank you all who supported, participated, or even shared the information. We had over 400 persons walk that morning, and over 500 persons had registered. So thank you all. Thank you all for assisting the Cancer Society. This weekend, we have a PAP and PSA clinic that will be held in Kemps Bay and also in Mangrove Key. So anybody on the call that is from Andros and in those area, please visit the clinic on Saturday from 9 a.m. to 2 p.m. And I think they have a special time for 7-day Adventist on Friday in Kemps Bay. You can go and get your screening done, your pap smear, and the men your PSA testing. It's only a prick of the finger, so don't be afraid. So that'll be happening this Saturday, March 15th. Our annual general meeting will be on Saturday, March 22nd at the Cancer Society headquarters. And the general public is invited to attend. This is where we let the public know what we have been doing with all your donations and our fundraising events, and also to tell you about our initiatives that will be happening later on in the year, like our upcoming ball that will be in May. So if you want to dress up and look fantabulous, look out for the information on our upcoming ball, which will be in May 24th. But the annual general meeting is on March 22nd. Light breakfast will be served. So it starts promptly at 9 and it ends about 1 o'clock. We like it to be brief, not to take away all your Saturday. Support group. For the year, we have introduced the virtual support group meeting. I know most persons don't like to drive at night, and even though time has changed now, and sun will set later, there are a lot of persons that don't like to drive at night. So we started the virtual support group meeting, and also for the Family Islanders to attend. I know we get a lot of persons from the Family Island that's stay at our Cancer Caring Center. So, they need support, they need encouragement, and they also need to hear from other persons diagnosed with cancer on how they pull through the process. So, more information, check our newsletter, our website. The virtual support group is going to be on this Thursday coming, starting at 5:30 to 7 o'clock. So if you're interested, drop us a note or give us a call, and we will share the link with you if you want to be a part of our virtual support group. So with that said, that is the end of our announcements. Oh, one thing. The Stride for Life shirts were beautiful. I should have had a picture of it to show you, but we still have inventory in stock. And if you would like to purchase a nice shirt, they have reflectors. So if you're doing your walking early in the morning, they have reflectors on the shirt that, cars can see you exercising on the road. And the shirts are only $15. So if you're interested, please visit or call the Cancer Society. I will post the number in the chat if you're interested, or just drop on by. Thank you so much, and I'll hand it back to our president, Rochelle.
Thank you, Erin. Thank you for those announcements. And yes, those were very lovely shirts. They actually look like sunrise or sunset, so got to get you one. So now we'll move on to our main event for the evening, and that will be with our speaker, Dr. Flloyd Carter, and Flloyd is spelt with 2 L's. So Dr. Flloyd Carter, a native of Barbados, completed his undergraduate and postgraduate training at the University of the West Indies. And trust me, he has a lot of letters behind his name to prove that. He obtained his gastroenterology training at the McMaster University in Canada and received additional training in pediatric gastroenterology. He serves on the consultant staff at Doctors Hospital. He's a fellow of the American College of Physicians and a member of the American College of Gastroenterology and the Association of West Indian Gastroenterologists. His research interests include Helicobacter pylori. I hope I pronounced that correctly. If not, you could correct me when you get started. In the Bahamas and Cochrane meta-analysis. Dr. Carter maintains a private practice, the Gastroenterology Clinic Bahamas, specializing in the diagnosis and treatment of digestive tract diseases. He provides comprehensive gastroenterological services and performs endoscopy and colonoscopy from 3 outpatient endoscopy units, the FMC Blake Road, Nassau, FMC Eleuthera, and Oak Tree Surgical Suites. Additionally, Dr. Carter has been internationally certified at the Orbera Center of Excellence in Gastric Balloon Placement. So now I turn it over to you, Dr. Carter.
Thank you very much. First, let me do some technical stuff here. Can you guys hear me well?
Yes.
Yes, we can.
And I'm going to try to see if I can share my slides. And then all right, are you seeing the slides properly?
Yes.
Yeah.
Perfect. All right. First, let me say thanks to the organizers of the Cancer Society for kindly asking me and having me to give this presentation. It's always a pleasure to do this. The first thing when we get a call to speak about colon cancer, and this month we have many calls to do that, is to decide how to present this information in a new way. I'm sure you've heard the information before, how to present it in a way that will still give you the required information that would be necessary for us to take home. And then it came to me that we are living in an age now where it seems everyone and their child has a cell phone, smartphone, a computer, and with that, they are able to post almost at any time, any information, and almost pretend to be experts in any topic that they can choose. And it's almost become an essential skill to be able to distinguish between what is truth and what is lies, what is fact and what is myths. So today we're going to approach our discussion by looking at how do we debunk some of these myths about colorectal cancer. And then hopefully we can have a couple minutes at the end of the presentations to bring it home by looking at a few cases that I've seen recently. So let's get on with it. First, I have no conflicts related to this presentation. So the first myth here that we hear often is I don't have a family history of colon cancer, so I do not need to get screened. So is that true? In that if there's no family history, there's no risk? Let's look at it this way. 25 to 30% of patients with colon cancer, 20%, 25 to 30% of these cases are familial. What that means is that these patients have a family history of colon cancer. So let's put that statistic in a different format. That means 1 out of every 4 people with colon cancer have a family history of colon cancer. And it's very important to know if you have a family history, because a first-degree relative with colon cancer, a parent, a sibling, or a child, will increase your risk by as much as 4 times higher than someone who do not have that history. So that's important. But if 1 out of every 4 have a family history, that also means that 3 out of every 4 patients will have no family history. That's important to know, because this is exactly what we see in our clinical practice. The majority of patients who are diagnosed with colon cancer have no family history whatsoever. And in many cases, they are the first persons in their family to have the diagnosis. So some important facts to note here. Colon cancer is very common, and this is reasons why everyone should get screened. It is the 3rd most common cancer worldwide. The most common is breast, then lung cancer, then colon cancer. And it is the 3rd most common cancer here in the Bahamas. Prostate being the most common, then breast cancer, then colon cancer. Look at this estimated lifetime risk. It's said that 1 out of every 24 men and 1 out of every 26 women will get colon cancer in their lifetime. And that is very important. That shows you that once you have a colon, you are at risk. So most patients who are diagnosed with colon cancer do not have a family history. So how do we conclude? This is evidently most commonly a myth. So we recommend that you do not have to wait, or do not have to decide if there's a family history in order to get screened. Everyone should get screened. And we recommend that you get screened at the age of 45. At the age of 45. First-degree relatives, if you have a family history of colon cancer and that is a first-degree relative, you should start your screening at the age of 40, or 10 years earlier than the age at which your family member was diagnosed. For example, if your family member was diagnosed at the age of 50, you should start at the age of 40. If your family member was diagnosed at the age of 40, you need to start at the age of 30. So that's very important. The first myth is no family history, no risk. That is definitely false. Everyone should get screened, and you should get screened at the right age. Let's look at the second myth. This second myth basically states that colon cancer is an old white man disease. I don't know if you've heard this, but this is a myth that some people think. So this is a little more tricky in that you can, there's some parts of this statement that is true and other parts that is not true. So the devil is really in the details. So let's look at it in more detail. But first, I have to say that regardless of age, gender, and race, all can be affected with colon cancer. Let's look at age. The risk of colon cancer increases with age. That's true. So if you compare someone who's over the age of 65 compared to those who are under the age of 50, those are over the age of 65 are 3 times higher, have a 3 times higher risk of developing colon cancer compared to those who are under the age of 50. Fortunately, what we have noticed is that over the last decade, the rates of colon cancer have been steadily decreasing in those who are over the age of 50. And that is good. And that's because of thoughts like this. More and more colon cancer awareness. More and more people are getting screened. So that's good. But what we have also noticed is that over the same time period, the rates in those who are under the age of 50 have been increasing. We are seeing an increased incidence of colorectal cancer in those who are under the age of 50. And that is concerning. We can talk about reasons for that, but that is a very concerning trend. So therefore, everyone should be concerned and should be very intentional in getting screened at the recommended age. Look at gender. Over lifetime, the lifetime risks of both males and females are the same. But men have a slightly higher risk than women. So how does it get to be about the same? It's because women have a longer life expectancy. So the risk averages out over their lifetime. So both males and females need to be screened with the same urgency. What about race? It is definitely not just a white person's disease. In fact, Blacks and African Americans have a higher risk of colon cancer than our white counterparts. And they have a higher risk of dying from colon cancer compared to the other races. That's very important. Not only we have a higher risk, we have a higher chance, a lower survival across all stages of colon cancer. So this second one is definitely a myth. Is it an old white person's disease? Definitely not. It is true, it's more common as you get older, but more and more young people are being diagnosed with colon cancer. So that is important. Men and women have the similar risk, and Blacks have a higher risk than other races. Let's go on to our third myth. This myth basically states that there's nothing you can do to reduce your risk of getting colon cancer. There's nothing you can do to reduce your risk of developing colon cancer. Let's look at the risk factors for colon cancer. I'm listing them all here. And this list is not exhaustive, but we can see that we already mentioned age. As you get older, your risk increases. And genetics. If there's a family history, typically there are genes or genetic risks that you can inherit that will increase your risk of developing colon cancer. These are risk factors. Look at the other risk factors here. Physical activity. The less active you are, the higher your risk of colon cancer. Patients who are overweight or obese have a higher risk of having and dying from colorectal cancer. And then you know that smoking and alcohol use raises the risk of colon cancer as well as having diabetes. But this next slide is where I think is more important. The items in red, these risk factors are not modifiable, meaning you can't change them. Your age is your age. You can't change that. Your family history is your family history. That's already baked in when you are born. Those are not modifiable. So it's true, you can't change those risks. But all of the others listed here in blue are modifiable risks. So physical activity, overweight, smoking, alcohol, all of these are risks that can be changed in your favor. So you can reduce your risk of colon cancer by simply living better, making better lifestyle choices. And it's estimated you can reduce the risk of colon cancer by as much as 54% by just doing 3 simple things: having a healthy diet, being physically active, and maintaining a healthy weight. These three things alone can reduce your risk of developing colon cancer by as much as 54%. What does it mean to have a healthy diet? We all know it means you have to eat more fruits, eat more vegetables, and reduce your intake of red meats and avoid eating processed foods. I can't stress this enough. We know that red meats are possibly carcinogenic. We know that the heme that makes the meat red under high heat can be broken down into mutagenic chemicals. And if you eat too much of these meats, eventually you're ingesting more and more of these chemicals that can induce the changes in the genes that can cause colon cancer. And processed foods, we should not be eating. Processed foods are definitely carcinogenic. That we know that because of the contents in processed foods. So the hot dogs, the deli meats, the corned beef, the things that are common in the diet, these things we should truly be removing from our diet if we want to reduce our risk of colon cancer. Being physically active really just means you want to at least get 150 minutes of exercise every week, and you want to achieve and maintain a healthy weight. That is very important. You do that and you're already 54% along the way to reduce your risk. You can further reduce your risk by adopting other healthy choices, limit your alcohol intake, and stopping smoking. So, of course, the things you can do to reduce your risk. And then, of course, you can get screened. We have mentioned this. You can get screened. And this slide here, we know that colonoscopy, let's go back here. This slide here basically gives you the available screening tests that we have today. The ones in the top line are your stool-based tests. The FOBT test used to be the first line. We really do that nowadays because it's not a good test. The FIT test is the test that's offered now in our National Health Insurance Scheme. And it is a way to test for microscopic blood in the stool. And if it is positive, you should go on to get a colonoscopy. This is a reasonable screening test that should be done every year. Some places do it every 2 years. And then there's the virtual colonoscopy, which is a CT scan of the abdomen that allows you to visualize the colon and try to identify any lesions or polyps. Of course, if you identify any problems, then you will have to get a colonoscopy in order to have it removed. And of course, what we consider the gold standard screening test, which is the colonoscopy, which allows you to be able to not only identify the lesions, but also remove them. So a colonoscopy, for example, can reduce your risk of colon cancer by as much as 69%, as much as 70% by having a colonoscopy with polypectomy. And it can reduce your risk of dying from colon cancer by as much as 88%. And that's why we say 90% of the patients who die from colon cancer, 90% of these deaths were preventable, mainly by this simple statistic that I've shown you here. Compare that to the other screening test, which is the FIT test. It can reduce the risk of dying from colon cancer by about 33%. So this slide, I always put this in every presentation I have because it's important to see this. A normal colon going to a polyp center picture to cancer to the far right. This process is estimated takes about 8 to 10 years. A colonoscopy, which is a camera inserted through the rectum, looking along the lining of the colon, enables you to see these polyps and remove the polyp, thereby preventing this polyp from being able to grow into cancer. That's simply the reason why screening reduces your risk. It helps you identify lesions, hopefully at early enough stage before it's turned to cancer, removing particularly the polyps so that they are no longer able to grow into cancer. So we've demonstrated that this is definitely a myth. There's a lot you can do to reduce your risk of getting colon cancer. Simply healthy lifestyle, making healthy choices, and get screened. Any screening test is better than none at all. So discuss with your trusted physician which one is right for you and get screened. This is another myth. This is a good place to put this myth. A colonoscopy is painful. And we hear this a lot. I don't want a colonoscopy because it's a painful procedure. Is this a myth or is it true? This is one of the most common myths, unfortunately. And let's hope we can debunk this myth today. A colonoscopy should not be painful. Should not be painful. Probably the most common response I get at the end of a procedure was, is that it that really wasn't that bad. And that's very common to be said, because a colonoscopy is done under a light sedation. Patients are in a light sleep, and when they wake up, the procedure is completed. The night before, which is the laxative flush that you get, doesn't taste good, but is not painful. So a colonoscopy in general is a relatively small inconvenience compared to potentially missing an early onset colon cancer. Minor inconvenience for a great benefit. And that's how I try to explain this to my patients. So this is a definite myth. Colonoscopies should not be painful. So let's look at one more myth before we look at one or two cases. It looks like we are running good on time. I don't have symptoms, so I don't have colon cancer. Now, here's the fact. More than half of the people who are diagnosed with colon cancer have no symptoms. So you cannot wait until you have symptoms in order to go and get checked. That's the whole reason for recommending screening. Screening should be performed when you think you are healthy, before these symptoms occur. And the symptoms that we are concerned about would be changes in your stool. You're previously regular, now you're constipated, or previously formed stool and now persistently loose stool. That changes in your bowel habit is a concern and should be checked. If there's rectal bleeding, should not be assumed to be hemorrhoids, which is overwhelmingly what people think. Go to your doctor, get checked. Abdominal pain that's persistent, if there's unexplained weight loss, these are symptoms, what we call red flags, that definitely require you to come in to get checked. But usually once symptoms develop, the disease may be more advanced. So we want to encourage people to get screened before any symptoms develop. So this is evidently a myth. If you don't have symptoms, you don't have colon cancer. That is overwhelmingly false. All right. So for the next 5 to 7 minutes, because I want to leave some time for any questions, I'm just going to look at two cases I've seen within the last couple of months. And I don't have to dig too far to just see cases. And that's unfortunate. We have many cases being diagnosed every week. Patients with polyps, patients with cancer. And I'm hoping that these cases will at least use them to bring home the point of the importance of getting screened. This patient was referred just a couple of weeks ago, February 2025, 56-year-old male who was referred by his urologist for a colonoscopy. And the patient reported having normal bowel habits other than some intermittent rectal bleeding, but no other symptoms were reported. No prior colonoscopy, no family history, and physical examination was totally normal. And patient was, I agreed with the urologist, this patient should have a colonoscopy. Just a few points here. Remember, this patient is 56 years old. We recommend that you start screening at what age? 45. So if this patient had followed our recommendations, they at least should have had at least 2 colonoscopies already by the time they're 56. Other point here is don't wait. These symptoms, patient was having intermittent painless rectal bleeding for a while, assumed it was hemorrhoids in this case, and just didn't go to get checked. But eventually came, and this is the pictures of his colonoscopy. I don't have a pointer, so follow me. Bottom left image. What you see here is an instrument around the base of what is a very long polyp. So this is what we call a polyp on its stalk. The head is distal to you. And this was a fairly big, about 3 centimeter polyp that we were able to, in the colon. A little further up, another polyp here to your right. You can see how polyps come in various shapes, various sizes. And then in the right side of the colon, there was this lesion. You can already see it looks a little different than the other, two that we've seen. It looks a little more angrier and a little more significant. This was a concern to me. We were able to remove all of these polyps. And you can see at the bottom image how the polyp looks after it's being removed. And the one that was concerning, we were able to remove that using a special technique, which we call mucosal resection, to lift it off the wall and scoop it out. And what you see at the bottom is a metallic clip that's placed to close the defect, because this was a fairly large lesion. The pathology, when we send these polyps away, came back showing that the polyp to the top left was just a tubular adenoma. Just a quick lesson here. Adenomas are the type of polyps that leads to cancer. They are precancerous. There are different types of adenomas with varying risks of going to cancer. They're tubular, tubulovillous, and villous. I don't want you to become a doctor here, but let's keep that in mind. The tubular are the lowest risk, while the villous are the highest risk. The top left picture came back as a tubular adenoma, and the pathologist said there was no sign of the polyp turning. There was no dysplasia. Top right polyp was a tubulovillous adenoma. So this is a higher risk polyp, but again, there was no dysplasia. But the one we were concerned about, bottom left, the pathologist said this polyp was already cancer arising from a tubulovillous adenoma with a lot of dysplasia. So this polyp was already cancerous. Fortunately, the pathologist said that the margins from where we cut the polyp off were free from both cancer and adenoma. So we were fairly confident and happy that we were able to reset this cancer at endoscopy. So this patient had a CT scan of the abdomen was ordered for staging, and our plan is to have an early repeat between 3 to 6 months of this patient. Lessons learned here is that, patients should, that cancer was growing likely for over 10 years. So if we had done a colonoscopy at age 45, we've definitely picked that up at that stage and remove it. Many points of intervention to prevent the development of colon cancer. This patient got lucky. The timing was just right, but in many cases, it is not so. One other case before I finish. This one was a 65-year-old female who was recently diagnosed with breast cancer, had a right mastectomy, and her surgeon referred her for a colonoscopy. And this was just in December. And the surgeon was concerned because he did a PET scan, which is a special scan that many cancer patients receive. After the mastectomy was done, that showed some suspicious activity in the right colon. So he sent her to me to say, take a look at this right colon and see what you see there. Patient had absolutely no bowel symptoms. Had never had a colonoscopy, no family history of colon cancer. Of course, we offered a colonoscopy and the patient accepted, and this is what we found. Small polyp, little pimple, left slide. Bigger polyp, this was in the right colon, smaller, but none of these are concerning to me. But then right in the right colon, there was this polypoid lesion here that was very suspicious. And this is right on the gray area for endoscopic resection, but after examining it, there was a part of it that was very suspicious to me, and we opted not to remove it, biopsy it, and tattoo it from the inside. So, because I suspected this will need to be removed surgically. And as expected, the pathologist came back as showing that this was an actual cancer arising from a polyp that was tubulovillous with extensive high-grade dysplasia. This patient went on to get successful colon resection and is doing very well at last time I heard from her. So let's conclude here. Colon cancer is common, and most cases arise in patients who have no family history. So don't get into lulling a sense of security saying, I have no family history, so I'm fine. The majority of patients have no such history. But if you do have a history, you should definitely get screened at an earlier age. The disease is definitely more common as you get older, but younger patients are being affected. So any younger patients that are having concerning symptoms should get their colonoscopy done. And both males and females are affected with equal risk, and disease is more common in our population. Blacks are at an increased risk, and there's a lot you can do to reduce your risk. Your best protection is healthy living. I think this can be repeated for nearly every cancer that we speak about. Healthy lifestyle changes will reduce your risk, and get screened on time and at the recommended intervals. I can't say that enough. I hope today we have debunked some of the myths and given you some important information regarding colon cancer. Thank you.
Thank you, Dr. Carter. Very interesting, and I like the perspective because those are very common myths. We hear people say those things all the time, and so it's very good to debunk them. If anyone has any questions, we can take them at this time. You can either open your mic and ask your question directly, or if you put them in the chat, we will read them out for you.
Good evening, all. Dr. Carter, thank you so much for your presentation. I truly appreciated you sharing, and I loved the way you presented in terms of myths, because I was a patient myself. I am a cancer survivor from colon cancer, and I was the first of my family. So that's a confirmation to the fact that, you know, you just can't go with the fact that there's no family member that would have had it prior to your revelation of it. And of course, the screening is just so important. So I thank you for sharing this important information this evening.
Good. Thank you for confirming that. Yeah, I mean that's common. Most people have no family history, so don't be too secured in saying I have no family history, so I don't need to get checked. There's a reason why we recommend screening, is because it is a common cancer.
Question. This is Colon Cancer Month, March, and I think most of the facilities that do the colonoscopy may be running a discounted price, because, you know, being at the Cancer Society and seeing persons being diagnosed with cancer, their fair cry is they can't afford the colonoscopy because it's very expensive. But this month being Colorectal Cancer Awareness Month, are there any discounted rates so persons could jump on and get their colonoscopy? Especially me, I haven't had one. So
Yeah, thank you for that question. The answer is yes, and it is true that colonoscopy is expensive. The typical price, regular price for colonoscopy, cash paying patients, can run you easily $2,500, easily. regularly. During the month of March, all of our gastroenterologists have we all reduced the price by nearly 50%. The cost now is about 1,500 plus VAT for a colonoscopy, and that's still expensive, but it's definitely much more affordable to get it done during this period. So if you're considering, and that is within your wheelhouse, definitely reach out to myself or one of my colleagues to get it done. But here's a fact that there are still other screening modalities. So no screening is bad. Any screening test is better than none at all. All right. So if you everybody should have signed up to NHI by now, and they can get a fit test free of cost. So everyone can get at least that screening test done. There's no excuse. But if it is positive, yes, you will need to get a colonoscopy to take a look. But it's true that the colonoscopy gives you your best rate of reduction, but any screening test I would recommend so that you can definitely reduce your risk there.
Okay, we do have some questions in the chat. Some may say colonoscopy is quite expensive. Tell us what you propose as the method of screening for those who say they can't afford it. So we covered that. How long can you live with colon cancer?
Depends. Every cancer has to be staged, and the staging really affects the survivability of the cancer. The whole idea behind these thoughts is to prevent the cancer or detect it at stage 1 or 2. Those cancers have a good chance of being cured with the available treatments. If we're diagnosing cancer at stage 4, I don't think the best treatments are not able to do much than extend the life for very short periods. So the emphasis, and there's really very little effective treatment for any stage 4 disease. We want to detect cancers very early or prevent them altogether. There's an interesting question in the chat asking about what do I tell patients who have had a digital colonoscopy, which is a virtual colonoscopy. Well, they had a bad experience, but most cases, a digital colonoscopy can be done safely, and it is one of the possible screening options. I tell my patients I do not recommend it first line because you still have to get the bowel prep, and it can be very uncomfortable. And if you find something, you still have to get a colonoscopy. So I recommend them, if possible, they should go to the colonoscopy. But there are some people in which a virtual colonoscopy may be the best choice, particularly those who are very, very ill and cannot get a sedation. And but in general, I recommend the gold standard, which is the colonoscopy. Hope that answers your question.
Okay. Somebody mentioned about the fit test, cost sensitivity of the test, and is it covered by NHI, which you said it is, and should everyone get this as a screening test annually?
Correct.
So I
Yes,
think
every
covered
year,
that.
get it done.
Mm-hmm.
Get it done. Yeah.
It's-
But by the way, if you've had a colonoscopy though, you don't need to get it. Okay.
Okay.
So if you had a colonoscopy, the doctor who've done your procedure will give you your recommended interval, right? So if you've had a colonoscopy that's normal, you typically don't require another screening test for 10 years once done properly.
Okay. What is the treatment for colon cancer? Not sure if you covered that already.
Well, yeah, and I'm not a cancer doctor, right? I'm into preventing cancer. But so when I diagnose a patient with cancer, I send them on to the specialists. We have cancer specialists who look after patients with colon cancer. The treatments typically are two: surgical and the oncologic treatment, chemotherapy, radiation. Those are the options available. And depending on the stage, it may be 1, two or all three of the modalities, but the cancer specialist will determine what's the best way to treat according to the stage of presentation.
Okay. I don't know if this is your question, but can't the FIT test be available at government clinics?
It's available at NHI. So wherever NHI is, I'm not sure why it shouldn't be available in a government clinic because it's part of the National Health Insurance. So you should ask if you go to a government clinic.
Yeah, maybe it is.
Right, but I think it may be more because it's not done in the clinic, it's done at a lab. So you just need a lab that is connected to the NHI, and you can get your FIT test done free of charge. And it's not an expensive test if you want to pay for it yourself. It's really a simple stool test done once. Absolutely no dietary restrictions needed before the test. Just get the stool test, send that in, and you get an answer. If it's positive though, go to the next step. The benefit is not in just doing the test, it's going to the next step if it's positive. The benefit is seeing if there's a lesion there that needs to be removed. That's very important.
Okay, so I think you may have just answered. Can you explain the FIT test?
Yeah, so the FIT test is fecal immunochemical test. It is a way to look for blood that you cannot see with your very eye, microscopic amounts of blood. It basically uses a immunological method to detect the blood. It's an antibody against the protein part of the blood, which we call the globin. So it is specific for the colon. The other occult blood test, if it was positive, I had to check both the stomach and the colon because it's positive if you're bleeding from stomach and bleeding from your colon. So I hated that test. The FIT test is specific for something in the colon. And because of that, it is a much better screening test.
Okay. How long does it take to get results of a FIT test?
Depends on the lab. So overnight, 2 days, depends on the lab.
Not a lengthy period. Okay.
No.
Okay. Do you have any other questions? That's all in the chat that I caught at least. Let's double check. Anyone else have any other questions for us?
Hello.
Hi.
Hi, go ahead.
Hi. Yes, I had a colonoscopy about, well, it wasn't 10 years as yet. And everything was clear, no polyps, everything was good. And then ironically, literally, this morning after using the bathroom and wiping, I saw blood. Sorry, I just joined the chat group just now, so I don't know what all really was said before that. But I've seen the first time I had the colonoscopy, I was sedated. I did go through the anesthesiologist. The whole process before that with the EKG, ECG, all those tests and everything, and then the anesthesia and the visit to the anesthesiologist. And then the day of the procedure, the anesthesiologist was there, put me to sleep. I woke up in the recovery room, but then I saw last week Dr. Munnings he was on the TV talking about where you don't need an anesthesiologist anymore. They can do localized anesthetics. You could be awake while the procedure is done. Is that still as effective as the one I did?
So you have a few things there. So number one, good on you. You got screened. If you see blood in your stool and it is persistent, you should still go and get checked. Go to your doctor to be checked out. Quite likely, it's probably related to a very benign condition at the anus and so forth. But still get examined, especially if it persists. As far as the method of doing the colonoscopy, it really depends on where your gastroenterologist was trained. Most
Okay.
places in the world do not use anesthesia and anesthesiologists. So I trained in Canada. We did not use anesthesiologists. So I have about 2 units where we do not use an anesthesiologist, and I have 1 unit where we do use an anesthesiologist. So both can be done. Both are quite safe. I use both techniques, but the majority of my procedures are done without the presence of an anesthesiologist. If I have a very sick patient, I would prefer, of course, to have an anesthesiologist present, but most of the routine screenings are in healthy people who can have a colonoscopy done safely without the need of an anesthesiologist. That's how I was trained, and that's how I perform most of my procedures. So either way is fine, but you are the patient. You get to decide. You are the customer. You prefer an anesthesiologist. Inquire to see whether or not your doctor is using one. And if you prefer that, go to a place where he uses one so that you'll be comfortable. The key here is be comfortable wherever you go, right? Be comfortable. But yes, you can have safe procedures done without the need of anesthesiologists. And as I said, the majority of places in the world do that. But in America, most of them use anesthesia. Yes, so both are correct, but both can be very safe.
Okay, and like I say, this really ironic that literally I just saw it today. So you're saying to me to monitor from here on, I mean, I'll still get it done, but you're saying to monitor to ensure that it doesn't happen again, or it isn't. I'm over 50 already. I'm 53, so I know I'm due for another one. I need to get another one done. It's just that it just happened this morning, so I got kind of concerned. But
Yes, so and you should go and have at least get an examination by your doctor, right? Always good to err on the side of caution. Be sure. So just a visit to your trusted physician does not have to be your gastroenterologist. Go to your trusted physician and then go based on that. So you really should at least don't make assumptions as a layperson. Let your doctor see you and give you their informed opinion about what you should do.
okay, yeah, because the first time I went about 5, 6 years ago, it was because I had hemorrhoids. Um, and when he treated me for the hemorrhoids went away, but he said as a precaution, he wanted me to do the colonoscopy, which I did. And then, like I say, there was nothing, yeah.
Okay, good. And nothing cures hemorrhoids. So hemorrhoids likely have come back. They always come back, unfortunately.
But it's not painful.
Yeah, so that's
I'm
fine.
feeling no pain at all.
Yeah, so it's okay.
I mean, it could still be hemorrhoids, even though I'm not having any symptoms, no stomach cramps, no pains, no nothing.
Yes, yes.
Wow.
Hemorrhoids typically is not associated with tummy pains and so forth and can be painless. Yes.
Wow. Okay, thank you.
Yes, sir.
So 2 more things in the chat. Thank you for that discussion. The first question is colon cancer a slow-moving cancer?
Well, it is a cancer that takes a while to develop, right? So we said about 8 to 10 years from polyp to go to cancer. But once we develop cancer, the cancer has a mind of its own, and it does what it does. Some are very aggressive, some are less. So it's almost like every cancer has its own character, has its own difference. So I can't really answer that question. Once cancer develops, you should get it out as quickly as possible because some people have colon cancer and it's super aggressive, and some have it that is a little more indolent, but it's really tough to be able to differentiate that by just a diagnosis alone.
Okay. And the last, this is from Dr. Shea. Dr. Carter, I know this is a colon cancer talk. You mentioned getting accredited for balloon placement for weight loss. Please explain to the public and we can reduce one of the comorbidities.
Well, one of the biggest comorbidities for nearly every chronic non-communicable disease we have is overweight and obesity. And the hardest thing to do is to get people to lose weight by diet and weight loss, diet and exercise alone. I don't know why, but it's just tough to get that done. And there are many different tools out there to help you lose weight, and the balloon is just one of those tools. And I just added it to have an additional option to offer to the patients for weight loss. It's really just a tool in the toolkit, just like any others that we have that we use occasionally. But yes, the emphasis, if we can reduce the obesity burden in our community, a lot of these cancer rates will drop. A lot of the diabetes, hypertension will drop. That is one thing that really requires a nationalized plan to get us healthier.
But on that note, aren't there certain don't you have to meet certain requirements for that? Don't you have to be overweight by so much over your BMI and all of that? There's a qualifying
Correct. There are qualifying standards. The balloon isn't covered by the insurance, as with most obesity treatments.
it is not?
It's not. The
Oh,
insurance
okay.
do not cover it unless in
Okay.
very rare circumstances, just like the surgery. So it's definitely considered a cosmetic type of procedure on their end. Another question somebody asked if a colonoscopy is covered by group insurance.
Right.
Yes and no. Most insurances will cover a colonoscopy for a diagnosis. Most insurances do not cover screening colonoscopies, which is interesting, but they will cover it for a diagnosis. Okay. So the answer is yes. You can get a colonoscopy done with your insurance, but there has to be a diagnostic code attached to it. To my knowledge, there's only one insurance plan that covers screening colonoscopies in the Bahamas. We're working hard behind the scenes to try to encourage all of them to follow suit, but that is a problem. So get a consultation. Your gastroenterologist can find a way to get your procedure done.
Dr. Carter, somebody messaged me on this, I guess as a sideline. When you mentioned about not having an anesthesiologist, does that mean that you don't put the person under anesthesia or you administer it yourself?
Correct. So is semantics here with type. Anesthesia is typically very deep sedation. Colonoscopy does not require that depth of sedation, which an anesthesiologist is comfortable putting people to sleep and stuff like that. You really just need a light sedation. And so we call it, we administer conscious sedation. We do not give anesthesia. And the procedure is done under conscious sedation, which is a very light sedation, but to you, there's absolutely no difference in the experience. You still don't remember the test. It's just a lot less medication in general, and same effect. So that's what it is, and it is given physician supervised. Correct? Yes, we administer the sedation ourselves. So you do get the sedation administered by the physician for the procedure.
I recall my very first colonoscopy. I was awake. I watched it, and the doctor was telling me what was happening, and I couldn't really feel anything, but I was awake. But all the ones since then, I've been asleep. So obviously, there's been a change over a number of years.
Yeah. So most people don't like to see that. Some people come in and request it. We let them see if they want to see. But yes, most people prefer to go after a very light sleep, wake up, and the procedure is done. And that is typically what is done worldwide now. I do have 1 or 2 colleagues that I will scope and they want to see what's going on, and we allow them to see that. But most people would prefer not to see. But yes, it can be done even without sedation.
Okay.
But when I had mine done, I definitely got that sedation. So that should tell you something.
So I guess somebody just wants confirmation if it's best to do the fit test first?
Depends. The gold standard is a colonoscopy. If you can get that done, get that done. But any screening if that's the screening that you can get done, do it. Just get a screening test done, right? But there's a reason why we say a colonoscopy is the gold standard. Let's put this here. I consider the FIT test a cancer detection test, as opposed to a colonoscopy, which is a cancer prevention test. Okay, because typically for a FIT test to be positive, typically you may have a polyp or a lesion that is fairly advanced in order for it to be bleeding for you to detect it. So the whole idea behind the FIT test is identify a bleeding lesion early enough so that it can be cured. We prefer to work a little further upstream. Find the polyp before it becomes symptomatic, get rid of it so we don't have to deal with cancer at all. That's our preference.
Okay, and one more question. Does not getting sedation cut costs? Meaning, I guess if you
Yes.
don't have an anesthesiologist, is it less cost?
Yes.
Hi. I was wondering, I'm also overdue for physical, which I'm going to do one time. What is that? I can't remember the name of the when you're doing the blood works that
Sorry,
tells that tells all right, sorry, that tells whether there's cancer present in your blood. Not necessarily colon cancer, but what is the name of that test again?
I'm not sure what you're referring to. I mean, there are cancer markers that people do, but there are a lot of the tests that have
Like
approved.
like the prostate, when you're doing the prostate test,
Yeah, so that's a PSA.
PSA, right? So the PSA number, that has nothing to do with the colon in terms of figuring out what's your PSA count then.
But no, so yes, the PSA is prostate specific. So
Oh,
no,
I see.
it's not affected. But that's definitely something that every male should be getting done, but it doesn't tell you anything about the colon.
Okay, and then too, if you do have some kind of cancer or polyps or is it necessary that you will have pain or you will not have pain in terms of abdominal pain?
You can have cancer and have absolutely no symptoms whatsoever.
Okay.
But yes, you can have symptoms that we mentioned, changing bowel habits, abdominal pain, rectal bleeding, weight loss. Those are signs that you should really get checked. But yes, you shouldn't wait on symptoms. You can have cancer without any symptoms. And the two patients I presented had no symptoms. Okay, so yes, very common not to have symptoms and still have cancer at the same time. Oh,
Okay.
another point before I know we're so close to finishing. That final case, I put that in there for a special reason. I've been seeing a lot of patients, not a lot, but an important amount of patients with both breast and colon cancer.
Wow.
And 3 of them in the last year had them at exactly the same time. So it's really important that we don't get too blind, blinkers on, and screen for all of the important cancers. So if somebody had breast cancer, definitely that doctor should also be telling them, have you gotten screened for your colon? Because we're seeing too many patients with both cancers at the same time, and that's being very concerning to us.
Okay.
Yeah.
Oh, sorry, go ahead.
No, go ahead.
Oh, no, actually, the question is for you, Madam Moderator. Is this going to be available after tonight in terms of to listen to again? Because like I said, I came in, 45 minutes into it.
Oh, yes, we have been recording the meeting, and so it'll be available on our website. I'm
Which
not
is,
sure the timeline. Erin, do you know how long it'll be before we'll have that available?
Well, as soon as Dr. Holliday does his editing, usually he gets it to me by tomorrow, and I have my PR guy put it on the website. And if you click under news, then you would see Dr. Carter's flyer, his post, and then underneath it that you would see, click on it in order to watch this meeting again. So
I see Dr. Halliday has put a link in the chat.
okay. Oh, see, he's done it already. Awesome. So Mr. Anthony, you see the link? Can you copy it, click it, and paste it to your WhatsApp or something? Send it to yourself,
Browser.
then you could watch it again.
For Dr. Carter, we have one more question, and that is, why is it suggested to have a colonoscopy every 5 or 10 years when so much could happen next?
Every test has a protection range. The FIT test every year, right? The virtual colonoscopy every 5 years. The colonoscopy every 10 years, mainly because the colonoscopy allows you to detect very small polyps. And if it's done properly and you don't miss any polyps, you should be fine for 10 years because it takes that long for a polyp to develop and grow into something significant. So you will catch it if your interval is 10 years. So trust your physician. The physician will give you the recommended interval and follow that interval.
So would you recommend doing the FIT test in between the colonoscopies?
Not
No.
necessary.
Okay. Oh, okay.
Right. If FIT is your screening every year, right?
Okay.
If you're doing colonoscopy as your screening, you should
10
do
years. Okay. So you don't need to mix and match them. Okay.
it. No, but you
Okay.
can, but you will still follow the interval. So if you have a colonoscopy that is normal, and at the end of the 10 years, you can decide you'll get your screening done with a FIT test every year, but you have to follow the interval for the test, the screening that you did.
I see. Okay. All right.
Sorry, one question about the screening and the testing. If it runs in your family, then you should do it more often. And the second thing is, I don't see the link. I maybe because I'm on my phone, so I don't see the link. So I don't know if you could repeat the website, please.
All right, let me ask you a question. It was a YouTube link, and then I'll let Holiday deal with that. Yes, if you have a family history of colon cancer, your risk is not average. So therefore, your intervals for colonoscopy is every 5 years, regardless if the colonoscopy is normal. All right, so you're considered an above average risk. So you should start earlier and get screened more regularly every 5 years.
So what if it's prostate cancer that runs in your family? Would
It doesn't
would it
affect the
still?
colon whatsoever.
No, I'm
Does not.
saying, okay, because it's cancer though, that doesn't count as in terms of doing it often for the colonoscopy then.
No, totally different organ.
Okay. Okay, got you. So the link, like I said, it's not showing up on my phone, so I don't know if somebody can help me with that, please.
Can you can check on the Cancer Society website
Okay.
and it'll be there. The link
Yes.
will be there.
Yes, go to the
Okay.
Cancer Society website, www.cancersocietybahamas.org,
Okay.
and click on the that says news.
Uh-huh.
And when you click on news, then you would be able to see the flyer of the meeting, and then we will have the link posted. It won't post tonight because my PR, he may post it tonight as well as he'll post it first thing in the morning. But
Right.
if you give me your number, I can probably send you the link.
Okay. It's 465 7250.
465
7250. You can send it on WhatsApp, right?
Yeah,
Okay,
okay. So you'll be able
thank
to
you.
watch that tonight.
Okay, thank you.
Okay, not a problem.
All right.
So if somebody else is asking the price on the colonoscopy and with the discount, I think
Uh, every office, my office is kept it at 1,500 plus VAT. I'm assuming that's what we all agreed to many years ago. So you really have to call the individual offices to see if that has changed because of inflation and so forth. But that's the base price. But understand that if we get in there and there's a lot to do, like a lot of parts to remove, the price might vary depending on what we have to do at the procedure. But it's definitely a significant discount. Take advantage of it if you can.
Okay, somebody said it's on our YouTube page. So if you go to YouTube, but I'll still send it directly to your phone, Mr. Anthony.
Okay, thank you. Thank you.
Okay, so I don't, if there are no other questions, I would like to thank Dr. Carter for his time and for his very, well, timely, of course, timely presentation. And also, like we said, the format very different, and, you know, a very good and unique way to present a topic that I think a lot of us have seen and heard a lot of before, but certainly bringing a lot home in terms of clarity on the topic. So thank you very much, Dr. Carter, and we hope that we'll see more of you, and I hope more of us on this chat will see more of Dr. Carter this month in getting those colonoscopy screenings done. Just a reminder that our next meeting next month, April, will be on April 8th. It'll be kind of early because the first of the month is actually a Tuesday. So the second Tuesday will be April 8th. And our featured cancer will be testicular cancer awareness. So let's all get on that call next week, next month, and we look forward to seeing all of you and each one bring one. So everybody enjoy the rest of the month and we'll see you in April. And thank you once again, Dr. Carter.
Yes, thank you. Thank you all. Good night.
Great job. Good night.
Thank you,
night.
everyone.
Yeah.
Awesome presentation, Dr. Carter.
Recording stop.